Rhinophyma is the result of severe untreated rosacea. Rosacea is a chronic inflammatory skin disease mainly involving the center third of the face. This condition is commonly described as a blushing red or pink rash accompanied by pimples. Rosacea occurs in adults and is characterized by chronic facial edema, persistent erythema, telangiectasia, dilated blood vessels, redness, papules, pustules, as well as the overgrowth of nasal connective tissue observed in its most severe complication, rhinophyma. This condition may be observed in men and women of different age groups, skin types, and races. It is more frequently seen in relatively older and fair-skinned patients, often with greater severity in men. Rosacea is also referred to as acne rosacea. The definitive etiology of rosacea is yet to be ascertained. Edema consists of a localized or systemic abnormally large quantity of fluid in the intercellular tissue spaces of the body. Erythema consists of superficial redness resulting from capillary dilation and congestion attributable to allergic reactions to certain inflammatory chemicals and drugs, infection, injury, irritation, and sunburn. A papule is a small circumscribed, solid, superficial skin elevation of less than 1 centimeter in diameter. A pustule is a collection of pus visible within or beneath the epidermis. A phyma is any circumscribed skin swelling or tumor that is larger than a tubercle, resulting from exudation into the subcutaneous dermis or tissue. Telangiectasia is the permanent dilation of pre-existing capillaries, arterioles, and venules, forming discolored focal lesions generally in the mucous membranes and skin. The characteristics of rosacea are acute erythematous redness of the skin resulting from capillary congestion, persistent edematous swelling due to unusually large fluid volume in the affected tissues, acute papular small circumscribed skin elevations, acute pustular accretions beneath or within the epidermis, the permanent dilation of small blood vessels forming discolored focal lesions usually visible in the skin, typical in telangiectasia. Rosacea is damaging to the skin barrier resulting in transepidermal fluid loss, skin dryness, hypersensitivity, peeling, and the stinging sensation. Erythema and telangiectasia are seen over the cheeks, nasolabial area, and the nose. Inflammatory papules and pustules can be observed over the nose. The absence of Comedos is a helpful tool to distinguish rosacea from acne. The histology of rosacea shown in the skin biopsy micrograph consists of enlarged, dilated capillaries and venules located in the upper dermis, angulated telangiectasias, perivascular and perifollicular lymphocytic infiltration, and superficial dermal edema. Concurrently, there is also solar elastosis. Four phases of rosacea. The pre-rosacea phase is characterized by a flushed appearance over the cheeks and nose for an unusual period of time accompanied by a stinging sensation. The vascular phase is characterized by redness, edema, and telangiectasia. The inflammatory phase is characterized by the development of papules and sometimes pustules. The late phase is characterized by the red bulbous nasal skin thickening of Rhinophyma, observed in the most severe rosacea patients. The four types of rosacea. Erythematotelangiectactic rosacea presents as flushing, redness, and telangiectasias, usually with the sensation of burning or stinging. It is considered to be the most common type of rosacea. Papulopustular rosacea presents as papules, pustules, and redness, sometimes misdiagnosed as acne vulgaris. Phymatous rosacea presents as a bumpy, rough, and thickened, irregular area, such as on the nose, chin, forehead, eyes, and eyelids. Ocular rosacea presents as redness, swelling, itching, and stinging of the eyes and eyelids, accompanied by foreign body sensations and sensitivity to light. Erythematotelangiectactic rosacea. Central facial erythema is most visibly prominent on the cheeks with telangiectasias. Papulopustular rosacea. Multiple papules and pustules on the central face lacking comedones sparing the perioral area are visible. Fhymatous rosacea. Thickened glandular skin of the nose creating a cosmetic deformity is visible. Ocular rosacea. Erythematous conjunctiva with increased watery discharge in the setting of acutely flared granulomatous rosacea is visible. Ocular rosacea with descementocele. Herniation of the descement membrane of the posterior cornea. Potential overlap of rosacea features with subtype classification. Keratin is a fibrous structural protein found in cells. Keratitis refers to inflammation of the anterior corneal epithelium relative to the cellular constituent. Rosacea keratitis is a severe form of rosacea due to inflammation and sometimes ulceration, along with conjunctivitis involving the cornea of the eye. Corneal inflammation may cause severe pain, corneal scarring, and impair vision. It is a complication of rosacea. Rhinophyma is a severe disfiguring nasal deformity consisting of sebaceous hyperplasia of the lower half of the nose and sometimes adjacent cheeks, being the most common type of phymatous rosacea. Rhinophyma is due to the proliferation of sebaceous glands and the underlying connective tissue. A flushed facial appearance is observed beginning between the ages of 20 and 30. The condition primarily affects white males over 50 years of age. Pre-Rosacea, Vascular rosacea, as well as inflammatory acne rosacea, consisting of dispersed papules and pustules, comprise the skin disease stages that respectively progress to the development of rhinophyma. Nasal skin thickening and consistent erythema in the presence of the aforementioned papules and pustules subsequently occur. The underlying nasal osseous structures remain unchanged. However, surrounding nasal skin hypertrophy, preferential nasal alveoli and tip expansion, and often airway obstruction is observed. Sebaceous fluids thicken, trapping bacteria in the glands. Antibiotic therapy is indicated in the event of infection before and after surgery. Hyperplasia and fibrosis of the sebaceous glands and connective tissue occur. Sebaceous gland destruction by edema and fibrosis occur in severe rhinophyma. Various forms of cancer present among rhinophyma lesions may be discovered by routine biopsy in skin cancer susceptible patients. Surgical correction is the main treatment for rhinophyma, which consists of tissue growth removal and minimization of large blood vessels for the improvement of appearance and breathing ability. Large nasal tip rhinophymas require septorhinoplasty to reopen each nasal passage adjacent to the nasal septum and correct the deformities present for the reconstruction of nasal function. Postoperative laser resurfacing may be performed to reshape the nose to further enhance cosmesis after about 6 months. Severe rhinophyma. Map summarizing rosacea. Variants of rhinophyma. Fibrous. Diffuse hyperplasia of the connective tissue. Variable sebaceous gland hyperplasia. Massive deposits of actinically damaged elastic material, vascular enlargement. Absence of pilosebaceous structures. Positive factor XIII staining. Fibroangiomatous. Nose is copper red to dark red, enlarged, edematous, with presence of ectatic veins, presence of pustules, presence of fibrosis, telangiectasias, inflammatory lesions. Less prominent sebaceous hyperplasia. Actinic. Nodular masses of elastic tissue, proliferation of sebaceous glands. Preoperative severe rhinophyma patient. This, as well as the subsequent photograph presented, are with the permission of Thomas Romo III, MD. Thank you, Dr. Romo. Postoperative severe rhinophyma patient. Dr. Romo performed the surgery. No presentations coming soon. Thanks for watching.